ahead though and get started. So today for our didactic, we have Dr. Alane O'Connor for the second time today. She actually did a presentation with us earlier, so she's all warmed up and ready to go. This is the good news for everyone. So many of you know Alane. She's obviously faculty for this group, but she's also is on the faculty of the Maine Dartmouth Family Medicine residency program since 2006. Her clinical work focuses on addiction medicine and the management of opioid use disorders using buprenorphine. She's helped develop an integrated medical and behavioral health treatment program that has served opioid-dependent pregnant women. Dr. O'Connor has published original research on infant outcomes following exposure to buprenorphine during pregnancy in many journals, including the Journal of Maternal, Fetal, and Neonatal Medicine, the Journal of Substance Abuse Treatment, and the American Journal of Obstetrics and Gynecology. Through her role as co-chair of Maine General's Opioid Steering Committee, she works to expand access to medication-assisted treatment in the primary care settings by mentoring other clinicians and practices. She also coordinates the residency's addiction medicine education as academic appointments at Dartmouth Medical School and Vanderbilt University. And then obviously she's quite busy, but in all her free time, she also helps other programs like helping to train emergency departments on how to do buprenorphine inductions, presenting for us on many different meetings, going to other sites and helping train them. So we appreciate all you do, Alane. We really do. You're very active in this work. And with that, I am going to turn it over to you and we will advance your slides for you.
Awesome, great. Well, thank you for having me. Delighted to be here and looking forward to it. So we shall get started. I'm going to talk about high-risk populations with a particular emphasis on pregnancy for a couple different reasons, but we'll also talk about some other folks as well. The first couple slides I know that they include, so it sounds like I can sort of skim through those. Did you want to move to the, yeah, this is sort of the background information I gather. To the next slide. And the next one. And yet another one. All right, perfect. So this is where I start. So again, I'm going to talk a little bit about pregnant and postpartum women, which has really been my love. I started working with pregnant moms in 2007, and we built an integrated program sometime thereafter, largely because we serve very rural patients in my population. And it's really been wonderful. I've cared for, I stopped counting it when we hit 400 pregnant women. So it's some amount above that. Talk a little bit about adolescents and some work that we're doing on that. Geriatrics, which is really a population that I think is understudied and not well understood, particularly as it pertains to OUD. And then homeless folks and recently incarcerated individuals. So next slide. So this is a nice chart that I like to start with. This just really captures that Maine has a very significant problem with pregnant moms with substance use disorders. It's very, very common. We have about 5 times the national rate. There's an article about that recently in the paper. We do lead the nation along with Maine, Vermont, and West Virginia. So it is a, an opportunity is the way I look at it to really help these moms engage in treatment and get the very best evidence-based care that we can provide to them. Next slide, please. Oops. So what about Maine? Here's another slide from a newspaper article, and it just really shows how much the rate has increased. So from 1.4% in 2006 up to about 8% in 2016. Some of the numbers have been variable the last couple of years. The numbers have gone down a little bit, but it sounds as if the deliveries have also gone down. The bottom line is it's about 1 in every 12 deliveries in the state, so it's a super common issue. I think in some ways we're actually identifying it more regularly, so we're actually getting more moms into treatment, which is positive. It is the 3rd highest rate in the US, as I mentioned. But I'm going to sort of sprinkle in various things throughout, which is really around terminology. So we've definitely moved to calling it substance-exposed infants as opposed to drug-affected infants or drug-affected babies. And the reason we've really moved away from that is that drug-affected was often substituted for drug-addicted babies, as you sort of have seen in headlines in the newspaper. And we really want to stress that babies can't be born addicted. They can be born affected or exposed to substances that may or may not be legal, but they cannot have an addiction. And I think it really helps reduce the stigma around this issue if we use appropriate terminology. Next slide, please. So substance use during pregnancy, one thing you need to be aware of is the vast majority of pregnancies are unplanned. So you can imagine that if a mom has a ongoing substance use disorder, she may not be, getting regular care, and certainly not focused necessarily on her contraception. So, and she may not have even had insurance before that, although that's certainly expanding with the main care expansion. But the vast majority of pregnancies are unplanned. So you need to just have a dialogue with mom about kind of what she wants to do. Sometimes it can be overwhelming because she might be presenting both with sort of uncertainty around her pregnancy and also uncertainty around, getting into treatment. And so that first visit can be really hard and, upsetting. And moms really feel like, many times have tried to quit before they come in and sit in front of us. And they're so physically dependent on the opioids, they're unable to do that. And there's a lot of shame and guilt around that, particularly if they're exposing their fetus to substances. They're often really motivated for change, but fearful of seeking treatment. Pretty much everybody has heard a horror story about child protectives sort of coming in the middle of the night and taking their baby and never seeing them again, which isn't what happens, but certainly sort of the folklore out there. And it's just important to stress, we talk a lot about the substance exposed infant reporting law, but to really stress that being in treatment is the right thing for them to do. It's the safest option for them, safest option for their baby. But it can be difficult for moms to engage and to not feel fearful. If you look at the literature, only about 6% of pregnant women disclosed using illicit substances in the past month. I think this is probably underreported because moms don't necessarily want to admit to this. I think we really miss in a lot of ways the alcohol use disorders during pregnancy because it's hard to screen for, and I think that many have learned that the appropriate answer is no, I'm not drinking. So it's just to be aware that there's oftentimes polysubstance present. Screening is critical. So ACOG and a variety of other organizations recommend screening at the first visit, and again each trimester. Sometimes moms aren't going to feel comfortable talking about it at the first visit. The 4Ps is probably the most commonly used instrument. That's the one ACOG endorses, and I have a slide on that. CRAFT is also an evidence-based tool that ACOG recommends for younger women. And then I included the ACE here mostly to just remind folks to really be talking about alcohol and constantly sort of focusing on that piece of it. I use the CAGE questionnaire in practice myself, but just to be aware that that may be an ongoing issue for moms. These are some of the risk factors associated with substance use during pregnancy, late initiation of care, high-risk behaviors, and other children not living in the home. I think I do want to really stress that some of these risk factors can be associated with things other than a substance use disorder, might be connected to poverty, trauma, domestic violence within the home. So don't sort of assume people have a substance use disorder. But if you look at the literature, these are some of the issues that are connected. Next slide, please. So this is the 4P screening instrument, super easy to use. It does sort of over capture, so it's very sensitive but not necessarily very specific. So if a mom answers yes, she may not have a substance use disorder, but what I really like about this tool is it's a safe and comfortable way to start a dialogue. My experience has been people don't know how to ask questions about substance use during pregnancy, so oftentimes they just don't, or they say things like, you're not using drugs, right? Which is not super effective. So this is a really nice instrument that you can use to ask really very broad questions. And then sometimes it starts a dialogue, like it may be a situation where their parents had a fairly significant substance use disorder. They themselves don't use, but there might have been trauma related to that, and it might become a safe opportunity for them to talk to you about that. Next slide, please. So substance use during pregnancy, I focus mostly on opioid use disorder, but I just want to remind folks that many women are using multiple different substances. One of the keys, you really need to confirm that diagnosis of an opioid use disorder. I sometimes find that folks start people in treatment really quickly without actually going through the process of defining that opioid use disorder. And I think that's true in general, not necessarily just with pregnancy, but I want to remind folks that if you're thinking about starting people in treatment, you do need to really go through the process of, pulling out the DSM-5 if you have to, and, checking off the list. But it's important to have that conversation, because if mom doesn't meet the criteria for an opioid use disorder, you're wanting to have a different subset of conversations. She may be high risk for a return to use, so you might still be thinking about putting her on buprenorphine, but sometimes that diagnosis is sort of a soft call. And so having that dialogue, what does it mean to be diagnosed with an opioid use disorder, is important to have. So if mom is physically dependent, on illicit opioids, she probably meets the criteria in a variety of different ways. But the key that you really want to stress to her is avoiding that withdrawal. I spent a lot of time explaining to mom that if she's in withdrawal, the fetus is not being well perfused through the placenta and what complications might be associated with that. Medically supervised withdrawal is not recommended, despite the fact that many women come in saying, I want you to help me get off this. And we have a long conversation about why that's not the standard of care. Methadone and buprenorphine now are both first line, which is pretty exciting. So that's ACOG and World Health Organization both endorse the use of either medication, which is wonderful that we have more than one thing in our toolbox. We talk a lot about the standard of care is MAT, medications for addiction treatment, and that I really believe that to be, particularly in the case of pregnancy, medication and counseling are both essential. So working with moms who are newly entering treatment on a variety of other issues. There's oftentimes co-occurring mental health diagnoses present, but certainly a lot of trauma and a lot of fear around what's going to happen to me and my baby during this pregnancy. I do want to stress that dose increases sometimes are required. Not uncommon particularly during the second trimester, as moms, their bodies are really changing and their metabolism is changing. And I try to normalize that with moms because I don't, if you don't sort of tell them that this can happen, sometimes they perceive if they're having, increased cravings or maybe some withdrawal symptoms, they perceive that they're doing something wrong. So they don't want to bring that up to you. So I try to explain that, as your body changes, sometimes your medication needs change. We don't tend to see a huge dose increase. It might be something like a total of 2 to 4 milligrams. But just to sort of normalize that for mom. And it doesn't impact the degree of neonatal abstinence syndrome. So that's important. Moms will often be like, well, I don't want to go above 8 because I don't want to expose my baby to more than 8 type picture. And we really try to counsel that there's no relationship between your dose and the severity of the neonatal abstinence syndrome. So the best dose for you is the one that you feel most stable on. Certainly women are using other substances. Marijuana we probably see most commonly. Well, actually nicotine we probably see most commonly, but marijuana is like half of our moms. We really try to spend a lot of time talking about the increased risk of stillbirth, increased risk of behavioral issues down the road with marijuana use, and really try to focus on why mom's using it. So if she's using it because she's really nauseous, sometimes you just really need to think about a bowel regimen. Because these moms usually are really constipated because they are both opioid dependent and pregnant, which means they are not having regular bowel movements. So you can aggressively manage their bowels, and sometimes that actually reduces their nausea because they're able to sort of, the whole GI tract is working a little more efficiently. We do try to talk about nicotine. It's about 85% of our moms are smoking. And so we really, we use a lot of the patch. Other types of things, I use bupropion for sort of the combined effect from a mood perspective. I don't use Chantix. It just isn't well studied in pregnant women, but we try to do, as much as we can around harm reduction and even reduction of use. So if you can get to 1 pack from 2, that's great. And just try to, any reduction in use of any of these other substances is very helpful. We're certainly seeing more stimulant use disorders in pregnant women. We didn't tend to see a ton of cocaine, but since meth arrived for us within the last year, we're seeing more of that in our pregnant women. And certainly, as I've already mentioned, alcohol is an issue. Harm reduction, limit exposure, we try to increase the frequency of counseling. I mean, things like meth use disorders, really the benefits are best if you enhance counseling. I will use medications as needed, and I really try to have the conversation around, risk versus benefit. I mean, you're tending to use medications that are category C because there aren't any other choices. And so, but, is it a better choice than, ongoing cocaine exposure? Probably. But it's sort of shared decision-making with mom. Next slide, please. So we offer integrated MAT and prenatal care, which I highly recommend, and I'll talk a little bit more about that. But we've seen that it reduces pregnancy complications, likely just because we see moms more. So we offer 2-hour group visits for our pregnant women with substance use disorders. They get their MAT, they get their substance use counseling, and they get their prenatal care all within that block of time. It really enhances the efficiency of educating patients. So we do a lot of education around postpartum depression and contraception and neonatal abstinence syndrome, and we can do that in the group setting, which patients really like. There's a tremendous benefit of peer support, which I didn't really appreciate when we started the program, how valuable that would be. But there's no group more stigmatized. I mean, people with substance use disorders are stigmatized, and then like within that group, the group that is most stigmatized are pregnant women. Like they experience shame from their families, from the pharmacy, from everyone they come into contact with. So the peer support that they offer each other is really remarkable. It also allows us to talk amongst ourselves. So sometimes a mom will say, you know, geez, I have this symptom, and you know, it's not clear if it's sort of an addiction-related issue or a pregnancy-related issue. So it lets us kind of brainstorm together about how to solve the mom's problem, and it, you know, it really enhances care, it reduces barriers. They don't have transportation issues, and they make all their appointments. More importantly, before we did this, they really didn't make their prenatal appointments anywhere near as frequently because they needed their medication. So those are the appointments they have. Next slide, please. These are some of the group topics. I just put those in. These are some of the things that we talk about during the postpartum group, or excuse me, during the prenatal group. Next slide. So monitoring management of pregnant women, they are at higher risk for obstetric complications. We think that actually looking at our data is probably around exposure to nicotine more than the buprenorphine, but that is out there. So we do monitor them a little bit more frequently. Infectious diseases are things you need to be watching out for. So about 50% of my moms have hepatitis C, and that is actually true across the state. I recently published a paper looking at statewide data. So that is very, very common. We talk a lot about that. Moms can enter treatment for that, but not till they're done with breastfeeding. We talked about vertical transmission. It's less than 5% typically. So, you know, it doesn't change your pregnancy planning or your delivery planning at all, but it's just something to be aware of. We're starting to see more HIV in our community from IV drug use, so that's out there as well. We definitely see cellulitis and endocarditis secondary to IV drug use, and just have that on your radar screen. They tend to be at an increased risk of sexually transmitted infections, and that's largely because, at least in our experience, sometimes there's multiple partners and they're engaging in relationships they might not otherwise want to, as a means of sort of securing housing or securing drugs or what have you. So it's often a very difficult situation that sort of furthers their shame and guilt, and it's very sad. They have an overwhelming number of mental health disorders, so very, very common, and we pretty aggressively screen and manage those as much as we can. We certainly use antidepressants. We actually published a paper that showed that moms who are managed with antidepressants were much more likely to be in treatment at 6 and 12 months postpartum. So we really try to use the safest medication, but aggressively manage those and get them into counseling as well. Next slide. So delivery, this is, you know, many, many questions for moms. You talk a lot about pain will be managed. You probably need more pain medications and more frequent dosing than someone who's not on buprenorphine. But we really try to just normalize that, you know, people are not going to think you're quote unquote drug seeking. You know, if you're in pain, speak up. We want to take care of you. And, you know, it doesn't mean that you're doing something wrong in your recovery. We talk a lot about confidentiality. What does that look like? You know, are you going to tell my mom if she comes to visit the baby, kind of thing. We do talk a lot about you know, your baby's going to be in the hospital for at least 5 days, and that is longer than for an infant typically that's not exposed to substances. So you need to think about what that looks like for you. If people are wondering why the baby's going to be there a longer period, you just kind of have to sort of prepare for those questions. We talk about the substance exposed infant notification law, talk a lot about breastfeeding. We certainly encourage it if mom's comfortable with it. She has a significant history of trauma that often does require some additional conversations or interventions, and sometimes she doesn't want to do it, and that's okay. Sometimes, for whatever reason, it feels more comfortable for moms to pump rather than doing breastfeeding directly, and again, that's okay. It is certainly compatible with being in treatment on MAT for both methadone and buprenorphine. It is contraindicated if there's active IV drug use, or excuse me, active drug use of any kind, or HIV positive. Next slide. So postpartum women, pregnancy, if you look at the literature, is really protective from overdose death. I mean, they tend to be really motivated and trying to get better. On sort of the other end, first year of postpartum we see a pretty increased risk of overdose death. And I think what happens here a lot is, you know, there's programs specifically for pregnant moms, and then they sort of are expected to transition somewhere else, and that care can be fragmented. Or we see postpartum depression that goes untreated sometimes, and that can further complicate the substance use picture. And certainly there's homelessness issues, there's child custody issues. You know, when you have a mom who delivers a baby and doesn't go home with that baby, they can be super high risk for return to use. So we worry a lot about those moms. We started doing infant-friendly postpartum MAT groups, which we've been doing for the last couple of years, which we love. The babies come with the moms, and we can talk about everything from MAT to depression to contraception to when do I start feeding my baby, you know, solids, and it's a wonderful environment for everybody. We talk a lot about contraception. We talk a lot about long-acting reversible contraceptives. Those are the standard of care for all women of childbearing age. So, you know, it's important, again, to not sort of say that we're treating you differently because you've got a substance use disorder. That is the standard of care for all women who are of childbearing age. Next slide, please. So there's many social issues and barriers. You're all aware of these, but they're present, and you just kind of have to be thinking about these issues all the time. Intimate partner violence is sort of overwhelming in terms of the prevalence of it, either currently or in the past. So it's just important that you spend some time alone with the mom just to sort of see how she's doing, if she's safe in her home. Next slide. Stigma, I could talk about this for a long period of time too. We're trying to race through these slides. You know, I think we did some stigma work with our moms through one of our HRSA grants, and these are just some quotes that moms had said, you know, and I think the last one is probably the one that I feel like I hear most commonly. You know, I felt like I was a horrible person, felt like I was a piece of shit, as she said. I didn't feel like I was worth it. I did not feel deserving of help. And, you know, that's a really common theme. I've done too much wrong to even be helped. And so working with that, you know, positive reinforcements is really important for mom. Next slide. So hope, these are some of the things that moms have said about after they've entered treatment. I'll just leave that with you. You all have the slides. But it's really powerful, you know, when folks are on track and sort of what their experience has been and lessons learned. Next slide. So what's Maine MOM? So you guys are probably going to be hearing more about this. This is a big grant that the state of Maine was just issued, $5.3 million over 5 years. We're one of 10 states to get this grant, which is super exciting. I'm the clinical lead on it, and we had our big kickoff meeting yesterday. So it's really designed to improve care for pregnant and postpartum women with OUD and their infants. It's really around creating a system-wide or statewide system of evidence-based comprehensive care. So we're using an integrated model and really outreach, stigma education, making sure moms know how to access services. We just really want moms to be able to access services across the state. We have a care delivery partner in every county, which is awesome. And we want them to access services as early in the pregnancy as possible. Next slide, please. These are the critical components. I've already mentioned it, but no wrong door. So no matter how women access the healthcare system, they're able to be screened and get connected with services. Group visits, MAT, increasing the capacity of integrated care teams, and then really public health outreach around education and stigma, I think is a really big piece, and I'm excited for that. Next slide. So adolescents, this is a group that I think, you know, is emerging, and I think we need to be thinking more about adolescents. Fatal drug overdoses increased pretty dramatically during that time period. Universal screening is recommended by the American Academy of Pediatrics. I put it in links here for 2 really nice screens from the NIDA website, and what I like about it is you can sort of click on the box, I'm the clinician or I'm the patient, and go through, you know, asking risk questions. And then if you go to the next slide, it will actually stratify your patient into one of 3 levels of risk. So no use, lower risk, or higher risk. And then it has really nice data that it will provide in terms of links or recommendations for what level of care your adolescent patient might need. And I think it's a helpful tool, again, around people who don't feel comfortable necessarily asking these questions. So it helps normalize the conversation around substance use, reinforce and promote healthy behaviors. And then I think really identify adolescents that might be at risk, and then as well as sort of guide interventions. I think, you know, I'm always amazed when I've given a couple lectures to the American Academy of Pediatrics in Maine, and, you know, that's a group that's really engaged in this. And when I ask usually before I start lecturing, you know, how many people in the room have their X waiver? And I was stunned by the number of folks in that room that had their X waiver, and I thought that was awesome. So I think this is a group that we can engage in this conversation pretty aggressively. Next slide. Okay, so there was a big study done looking at MAT and the use in adolescents over a 14-year period. Only 1 in 4 received either buprenorphine or naltrexone, and then there's a group of folks that were even less likely to receive it. AAP clearly recommends MAT in adolescents. If they have an opiate use disorder, they are super high risk for overdose. Certainly within a family practice setting would put in adolescents and have put adolescents in treatment. I try to work with one of our child psychiatrists as, to sort of share that, but our child psychiatrist at Maine General, for example, has his X waiver. So there's opportunities to collaborate there. But the pediatricians, like I said, in Maine have really been embracing this. And so this is a population, I think, or a group that you could work with if you needed support. Next slide. So geriatrics, again, I think this is not well studied in general, and that there's still this sort of ongoing dialogue about the use of opiates for chronic non-cancer pain. Certainly there's been a huge reduction in prescriptions here in Maine, but I think it's an ongoing issue for folks. Geriatricians, when they've been surveyed, express more concern around undertreating pain than substance use disorders. Very few older adults are screened. So I think this is particularly true within the emergency department. If an older adult takes a fall, they may not be asked questions around substance use or alcohol use in the way that if you had a, 30-year-old, they might be more aggressively, if they've had an unusual fall, there may be more questioning around what else was going on with that person. There's not yet reliable screening instruments that are specifically geared toward OUD and geriatrics. And then I think there's this assumption that sort of drug users, when I talk to in public about some of the patients I take care of, and people are sort of stunned that I have people in their 60s and 70s with substance use disorders, and I sort of wonder why they just think it miraculously goes away. But I think people perceive that like somehow it doesn't become a problem. Next slide, please. If you look at the literature, the definition of old sometimes varies as well. So it can be as young as actually 40 years old in some studies. Treatment admissions for OUD among those 65 plus is increasing. So this is something you need to be thinking about when you're seeing patients in the office. And then there's more older individuals using sort of harder street drugs, which I think people don't perceive that to be a group that would be using harder street drugs. There's two distinct types. So there's sort of early onset use and late onset. So, we see a lot of folks who are in MAT for long periods of time. So you're going to see folks who start in treatment in their 30s and 40s who will still be in treatment potentially at 60s and 70s. So there's sort of different needs. If you have somebody who's been in MAT for 20 years, they might be very stable versus somebody who accesses treatment later on. They do tend to achieve better outcomes, with older women doing particularly well. Next slide, please. So homelessness, I see a lot of that in my area. And I think when we think homelessness, I think people generally think like homeless shelters. But there's a lot of homelessness that's really couch surfing and kind of no permanent home. And I live with my uncle for 3 weeks, and then I live, with my cousin for 3 weeks, and I sleep on a couch. And so I think thinking about our own definition of homelessness is really important. Drug overdose death is the leading cause of death amongst homeless individuals. A third of those deaths in homelessness under 45. So really common, certainly more common than other issues. People, I think, perceive violence as being the #1 cause, but it is actually drug overdose. Community responses have proven very effective. So working with your other members of your community sort of treatment team, law enforcement, EMS, social service agencies. So getting folks into housing, and then, housing first, medication first, to sort of rapid access, having available treatment options through the emergency department, getting people into treatment as quick as possible. But then the whole idea around bringing treatment to the homeless. So, going to where they are and meeting them where they're at, both literally and figuratively, is really sort of the standard of care now. Next slide. Homelessness are at particular risk for soft tissue infection. That's not surprising. Infectious disease, co-occurring mental health diagnoses. So these often, limit their ability to engage in treatment if their mental health diagnosis is not well managed. So again, aggressive treatment of everything that's going on in their life, really where they're at if you can. Access to naloxone is critical. There are places that are using like naloxone drop boxes, which I think are really cool, putting them in areas where homeless folks might congregate. One of the biggest challenges I have is, if I have a patient who's homeless, is really medication storage and safety. So, I counsel about lock boxes and stuff like that in people's homes, safes to keep your medication safe from others or from your children. But if people don't really have a home, it's hard to, take good care of your medication. So that can be a big source of challenge for folks. And homeless shelters, in my experience, have very different degrees of control over people's medication. So I think having that dialogue and even advocating for your patients if you need to. Next slide, please. Recently incarcerated, so super high risk of overdose death. I think folks know this, but first 2 weeks after relapse, particularly for opioid naive patients, the risk of death is 13 to 40 times the public risk of death, which is overwhelming. This has really been the movement behind getting MAT in jail, so that people don't have this huge risk when they come out. And it's particularly challenging when you have folks who feel like they need to have substances in their system to be able to start MAT. Because the first relapse is often the fatal relapse, right, when they get out of jail. So we really want to be able to get these people in treatment before they have a return of use. Naloxone is essential. MAT is even better. If you can get both MAT and naloxone, it's a great thing. Patients don't need to be physically dependent to meet the criteria for OUD. So I think that's really important. So if you go back again to your checklist of opiate use disorder, particularly those who've been in jail for less than a year. I mean, it's pretty easy. These folks might have been actively using, they may be craving, high risk of return to use. Access to MAT while incarcerated reduces the overdose risk death after release by 70%. So if there's a group that we need to be intervening on, it's them. They're doing pretty remarkable work across the state, getting access. My experience has been, transition from the prison system has been a little more straightforward because the prison system has a defined release date. So if I'm taking over at the MAT for somebody who's coming out of, Wyndham or Warren, it's easier because, they get out September 11th at, 9:30 a.m. type thing. So it's easy to make that transition. Jail can be harder because people are often released early or they're held for some period of time and then released. So coordinating that care can be challenging, but my experience has been that if you can get somebody in the jail to really work with you, that's helpful. Next slide. And these are some resources if you would like more information. And I think that's my last slide. Oh, this is a slide. So this is a patient of mine who called my office, and my support staff typed this up for me. And I was so moved by it because I was having such a horrible day. And I think as we all think about the challenges of doing this work, so it was kind of a couple different lines, and I had to use some scissors. But he just called and said, he's gone through the worst, and he wants you to know, thank you for saving his life, and he's not going to go back to that life. And, it's just one of those things that I think, when we all suffer losses, I have a patient who's missing right now that is probably dead and will hit me very hard when, in fact, that is confirmed. But, remember that we're winning too a lot. And sometimes the losses are feel overwhelming. So, remember that this is the work that you're doing every day.
Great. Thank you for that. I know that was a lot of information. Alane covers all the special populations, as we like to call it. So I appreciate that, Alane. We have time for a few questions if folks have questions for Alane. And just as a reminder, if you're just joining us or joined us a little late, make sure you enter into the chat box if you haven't already, so we can capture that for attendance. But right now I'll open the floor for any questions for Alane.
I don't think I've ever had no questions, but that's okay. Surely there's something in there that I went too fast over. But you all have the slides and you also have my email. So